So this webinar will be on lower GI bleeding. And I think that this is something which a lot of people have asked us to do. So a lot of people have asked us to do something on this because I think most people are not 100% sure about what to do when it gets to the stage for endoscopy. And of course, that's the key part when it gets to the stage for endoscopy. So we've lined up a great session for you tonight, and I'll go through what will be happening. So the faculty tonight, myself, David Tate, gastroenterologist from Ghent in Belgium. My co-moderators, Roland Valori from Cheltenham, Gloucestershire, and Lobke de Zomer from Roeselare in Belgium. And then the faculty for tonight giving the lectures and doing most of the work. So thank you very much for joining us and being involved. John Anderson, Mr. Amin Haji from the UK, and Dr. Phil Leclerc, also from Belgium. So I think without further ado, John, I will ask you to introduce, because I think what we need to do is set the scene. And I think what we need to do, and what I know you're going to do, is give a practical overview for people in this space before we move on to a little bit more therapy, a little bit more evidence about what you can do and when you should do it, and then wrap up. So over to you, John. Floor is yours.
Okay, thank you, David. Let me just share my screen and we will start. Like yourself, I think this has probably been underexplored in terms of education and training, so it's a timely thing to do. My view is going to be reduce all the evidence we've got to a fairly simplistic approach, and the simplistic approach will follow this algorithm, really. You need to assess your patients properly. This goes without saying. That's a history and investigation. You'll need to resuscitate the ones that need resuscitating. You're going to find out that's not very many. And then you've got to make a decision on what investigation you need to do. You select the best investigation. And for some patients, they will need ongoing management. It seems fairly simple, and I'm going to try to give you the evidence supporting this. Now, I sat down, and when David asked me to do this, and I thought, what are my perceptions versus the realities? Well, my perception is endotherapy is largely around post-polypectomy bleeding. But actually, there's not very many of those. Most significant bleeds come in and they're observed and then they go home again without us doing anything at all. I think from my surgical colleagues, we tend to get the diverticular disease, which is bleeding, and all local anorectal, hemorrhoidal, benign stuff. And then the rest of the hospital send flare-up of colitis, which is sometimes a bit frustrating because they know what the diagnosis is. What they're usually saying is, can you assess the severity? I find ischemic colitis very rare, radiation proctopathy very, very common. And new polyps or colorectal cancers do present like this, but very, very rarely. Oops, where are we going? Here we go. Now, when I looked up, they said there's 3 big causes, and these were the 3 causes. I'm not sure that is true, and I'll give you some evidence to suggest maybe otherwise. But historically, diverticular disease plays a big role here. Angiodysplasia, ischemic colitis, as I say, I'm not so sure. I think there are local benign anorectal things which can present and be precipitated by anticoagulants. Now, I guess the things changed about 10 years ago, 10, 12 years ago. And initially there was a UK audit, and this is UK and European centric, which looked at 2,500 cases. Interestingly, less than a third of them had an endoscopic evaluation. And of the ones who did, flexible sigmoidoscopy was the most common thing to be done. Very few of them required any form of haemostasis, 2.1%, and lots of them had CT scans. And as you'd expect, diverticular disease was a big component of the diagnosis, along with the benign stuff. And then there was some data on antiplatelets, which wasn't really that relevant. But interestingly, in patients, there was rebleeding. There was also representation with bleeding in a significant number of patients. And this may be relevant in terms of ongoing management, and the decision is whether you need to investigate them or not. Now, here's some of the headline stuff. The patient stayed in hospital for 3 days at a time where beds were pretty tight then, and they're even tighter now. And this was largely to have a test done because it took them 3 days to get the test. Almost half of them would have managed without any intervention whatsoever. They could have gone home and be managed. They were managed conservatively, required no investigation. And this also highlighted the fact that we're using a lot of blood in these patients unnecessarily, and certainly we're not or we weren't promoting back then, a restrictive transfusion criteria. So you basically give them enough blood to get them going without over transfusing them. So I think we are probably wasting some of our blood transfusion resource. The clinically significant bleeds were very small, and more than half of them waited more than 2 weeks to have any sort of investigation at all. So this was sort of the base point, and then some of the same authors were then involved in developing UK guidelines. And if you want to know what the